Hello, this is Bharat Sachdeva. I'm the Program Director, Nephrology Fellowship at LSU Shreveport. I am going to review acid-base disorders, but I'm going to try and focus primarily um, on renal tubular acidosis because over the last few days we've had a lot of questions from residents and some faculty as well about diagnosis and review of certain renal tubular acidosis. And then I'm also going to review some of the common approach of how to manage patients with acid-base disorders and how do you approach the diagnosis. And also, how do you apply the concepts of diagnosis in your testing, which is obviously a big goal. I have taken some of these slides from an online presentation from Joel Toffel. For those of you who do not follow Twitter, I would urge you to look him up at Kidney Boy on the Twitter world. He is published a lot of good resources online on a lot of different topics, including acid-base disorders. Henderson-Hasselbalch equation probably is the basis of any acid-base equation. The equation first derived by Henderson back in 1908 and then put together in the current form, in the logarithmic form by Hasselbalch, was also at the start of the century, more than 100 years ago. Still holds good. And for any given acid, it's going to dissociate into a base and the hydrogen ion. And the hydrogen ion concentration can be calculated based on the Ka value for any given acid. And if you simplify the equation, and this is what I want you to try and picture when you are dealing with a patient with an acid-base disorder, the hydrogen ion concentration in the blood is directly proportional to the PCO2. So any condition that raises CO2 in the body, namely respiratory acidosis, will raise the hydrogen ion concentration, make you acidemic. And on the contrary, any condition that raises the bicarbonate concentration in the body will lower the hydrogen ion concentration now and will make you alkalemic. Probably the most common clinical presentation that we see in a daily practice is a low hydrogen ion concentration, and this low hydrogen ion low bicarbonate concentration, which raises the hydrogen ion, lowers the pH, and metabolic acidosis is the common diagnosis there. So let's assume if you take a normal person and I infuse hydrogen ions into that person at, say, time 0, within minutes of that infusion, that hydrogen ion is going to get distributed into cells, it's going to be taken up by proteins, and then there will be mechanisms in place to maintain that hydrogen ion in a form that does not exceed a certain limit. The hydrogen ion concentration is very tightly regulated at 40 milliequivalents per liter. The negative log of that is a pH of 7.40. A concentration above 40, 45, 50 is going to lower the pH to 7.3, and it's going to cause a lot of structural changes in the protein configurations, and these structural changes lead to dysfunction at the level of cellular receptors, the enzymes, and beyond certain concentrations of hydrogen ions, when it goes up to 60, 70, a pH goes to below 7, it's an extremely life-threatening situation, and life will not exist if that thing goes unchecked for a long period of time. So your body has come up with several regulatory mechanisms, the early distribution of hydrogen ions into different proteins. So the earliest buffer probably occurs with the hydrogen ion getting taken up by the albumin protein within the blood, and for every hydrogen that the albumin takes up, a calcium is given up, and that lowers the hydrogen ion temporarily. So if there are only, say, about 5 extra hydrogen ions in the body, those will be very easily accommodated. But now as you keep infusing hydrogen, now the hydrogen is going to move into the cell. For every hydrogen that moves in the cell, a potassium comes out to maintain electroneutrality, and that's the reason why you develop hyperkalemia with chronic acidosis. Ultimately, the lungs start compensating, and we'll talk about this a little more, in lowering the CO2 level. Remember that equation and the ratio of CO2 to bicarbonate. So if the hydrogen ion is high, you can bring it down by lowering the PCO2 levels. And ultimately, the final regulation, which occurs several days or sometimes weeks or almost 24 hours later, is the renal secretion of hydrogen ion, which is the only way that you lose hydrogen in milk. So let's review a case of a 19-year-old female who's developed a superhero who's developed progressive fatigue. You find that she's got hypokalemia. She denies the use of any diuretics or laxatives. Her blood pressures are on the low side. We get a BMP, and that's kind of important that you want to make sure that we get the BMP and the ABG concomitantly, because the changes in the blood chemistry will alter your ABG after some time. So if those are not collected together, there may be discrepancies between the two measurements. You see that the patient has severe alkalosis or alkalemia. The pH is high, the potassium is low, the chloride is low, and the bicarbonate is high. So it seems like there are a lot of numbers. Break it down and see how do you approach a patient with any acid-base disorder. So the first thing that you need to do is to look at the pH. Just looking at the pH is very simply going to tell you what is the primary state of blood. If the pH is more than 7.45, then you have an alkalemia. If the pH is less than 7.35, then you've got an acidemia. Simple step one. Once you know that this is acidemia, you have only two explanations to define why the hydrogen ion concentration is high if you have acidemia. The hydrogen ion concentration could be high because either the PCO2 is high, imagine that equation again, PCO2 is high, hydrogen is high, that's a respiratory acidemia, whereas if the PCO2 is normal or low, then it cannot be the cause of that acidemia. It has to be the bicarbonate. Look at the bicarbonate. If the bicarbonate is low, then you're dealing with a metabolic acidosis causing acidemia. So once you know your pH, then the second step you need to try and figure out is what is the primary disorder, and you have to correlate the primary disorder with the state of blood. So let's kind of look at that example again. So we had a patient whose pH is high, right? And then we look at the PCO2 and their bicarbonate. So here the PCO2 is high. So a high PCO2 does not explain why the pH would be high or the hydrogen ion concentration would be low, right? Because the PCO2 should give you a high hydrogen ion concentration. So this has to be a metabolic disorder, and we see that the bicarbonate level is elevated. So the primary disorder has to be a metabolic alkalosis in this given patient, right? So this is a very simple step 1, step 2, which gives you the diagnosis that the patient has alkalemia and the primary process is a metabolic alkalosis. Let's take another example. A 32-year-old female who's also had worsening fatigue, weakness, and muscle aches, right? Let's look at the numbers. So you've got a pH, which is low, a low serum pH, that means a high hydrogen ion concentration. And this particular patient, the PCO2 is not high and the bicarbonate is low. So that suggests, right, this would be a acidemia, and it appears because the bicarbonate is low, it's a metabolic disorder. Plain and simple, right? All right, so let's go on to a little more complex. All right, let's go to the next step here, which is to try and figure out how does the body compensate for any given hydrogen ion change. So if you have a condition where the hydrogen ion concentration is raised, right, it's higher, it could be either because the PCO2 is high or the bicarbonate is low, right? If the PCO2 is high, there is a respiratory disorder. The way the body will try and get that equation back towards normal would be by raising the bicarbonate levels up, right? So that's the metabolic compensation for an persistently elevated PCO2 level. And the opposite will occur if the bicarbonate was low, the patient had a metabolic condition, a metabolic acidosis as the primary disorder, the body will try and bring the hydrogen ion concentration down again by lowering the PCO2 level and bring that equation back towards normal. Now, the only thing that you will have to remember in an acid-base disorder or when you're taking your test or looking at a patient are these 6 formulae. Make it even simple. The one that you need to remember for metabolic acidosis is the Winter's formula. Stands ground for several decades now. A very simple calculation that gives you the predicted PCO2 for any given bicarbonate level, right? So when the bicarbonate goes low, your body compensates by recognizing an increase in hydrogen ion concentration that stimulates the respiratory center, and you start blowing off PCO2. And the reduction in the PCO2 should be within the physiological limits for that change in bicarbonate. And that PCO2 is predicted by the Winter's formula here. When there's metabolic alkalosis and the problem is an increase in serum bicarbonate level, you compensate by retaining PCO2, and the amount of PCO2 elevation should be 6 for every 10 milliequivalents increase in the bicarbonate level. So those two for metabolic conditions. When there is a respiratory condition, the compensation is divided into acute and chronic. And this division is primarily because the renal compensation for any respiratory disorder starts slow and peaks at about 24 to 48 hours. So the first 24 hours, any respiratory change can be compensated some by the kidney, and that compensation is usually a little less. So for a respiratory acidosis where the PCO2 has gone up, for every 10 that the PCO2 goes up, the bicarbonate only goes up by 1. And similarly for alkalosis, for every 10 that the PCO2 goes down, the bicarbonate may only go down by 1 or 2. But when there is a chronic condition, the compensation is a little more effective. For every 10 PCO2 change, the bicarbonate goes up or down by 4. So all you have to remember is the Winter's formula for metabolic acidosis, 1.5 times the bicarbonate plus 8 gives you the PCO2. The metabolic alkalosis, for every 10 milliequivalent change in bicarbonate, look for a 6 millimeter change in PCO2. And for acute and chronic respiratory acidosis or alkalosis, for every 10 PCO2 going up or down, for acute, the bicarbonate goes up by 1 or 2 for acute and 4 for chronic, or goes down by 1 or 2 or 4 for alkalosis. That's the only thing you need to remember for the test. So let's apply the Winter's formula. The expected PCO2, like I said, would be given by the amount of bicarbonate. Let's review our patient again. So those were the presenting. So the pH is low, so there is acidemia, right? For the bicarbonate of 17, the expected PCO2 should be somewhere between 31 to 35, and your patient's PCO2 is within the predicted range. So it would suggest that your body is adequately able to compensate for that given change in bicarbonate, and this would be a appropriately compensated metabolic acidosis. If the predicted PCO2 was less than the patient's PCO2, let's say you predicted that the patient's PCO2 should have been, say, 25. Just taking a hypothetical example, and you see that your patient's actual PCO2 is higher, that would suggest that your body is unable to, or is not able to, get that PCO2 level down to where it should be for that given change in bicarbonate, suggesting that there is a problem with the respiratory compensation, and hence a double disorder where you have a metabolic acidosis as the primary plus a respiratory acidosis. The metabolic acidosis should then further be classified based on the amount or the type of anion that is associated with the hydrogen cation, right? And these are divided into when the hydrogen increase is associated with chloride as the only anion, we call it the non-anion gap metabolic acidosis, whereas all other anions will contribute to the anion gap metabolic acidosis. Let's review the positive and the negative commonly measured electrolytes on a daily basis on our BMP. The most commonly measured cation is the sodium. We really don't measure daily basis the magnesium and the calcium. Potassium is a very small amount, so it's usually not included in the calculation of an anion gap. The negatively charged anions, chloride and bicarbonate, account for a bulk of it, but the net sum of sodium is usually higher than the sum of chloride and bicarbonate, and this difference between the two is what we account for or label as a anion gap, a gap between sodium, the cations, minus the two most predominant anions, the chloride and the bicarbonate. In reality, there is no difference in the positively and the negatively charged particles, and the net sum of all positives and negatives has to be equal. So when you have a metabolic acidosis, you can have two ways by which the bicarbonate goes down. You can have the chloride that may go up and replace the bicarbonate. There is no change in the difference between the sodium level minus the sum of chloride and bicarbonate here, and the anion gap does not change, and this is what we call a non-anion gap metabolic acidosis. You can have another scenario where certain organic anions, and there are several different mnemonics by which we could memorize different organic anions that can be affected, may go up, and this increase in the organic anion takes up the bicarbonate. The chloride levels are not changed, but now the sum of chloride plus bicarbonate is going to be much lower, and the difference between the sodium and the combination of chloride and bicarbonate is going to increase and contribute to a high anion gap metabolic acidosis. So this is what accounts for the anion gap. And under normal physiological condition, it seems like albumin plays a big part of that anion gap and contributes to the anion gap in a big way. So this has clinical implications that in situations where the albumin level may be low, the anion gap can physiologically be lower. So let's again looking at an anion gap in patients who have under normal conditions, sodium, chloride plus bicarbonate, that's your gap. If you have anion gap acidosis, you have an increase in anion gap, but no change in chloride concentration, and the bicarbonate levels go down. So this would be the B is a high anion gap metabolic acidosis. And then in certain conditions where the chloride replaces the loss of bicarbonate, that would be your non-anion gap metabolic acidosis. So looking at the example from that earlier case, the anion gap normally, which should be about 12, it does vary from lab to lab. Normal anion gap can be anywhere between 8 to plus minus 4. One other clinical pearl that has been recognized of late is that the anion gap may be more patient specific rather than lab specific. So you may have certain patients who tend to run a lower anion gap, predominantly 4 to 6. And what I do try and do is to go back and look at the anion gap under prior conditions in the prior visits, and when the patient was absolutely normal, if the anion gap was say 6, and then now the patient has come in with some clinical derangement and the anion gap is 11, maybe that is a elevated gap for that given patient, even though the lab suggests that that may be within the normal limits. So that's a good way to try and make sure that you do not miss a subtle elevation in gap, which may be clinically significant, but not sometimes relevant, or not sometimes evident on the first exam. So in this particular patient, when we put in these numbers, we get a number that the anion gap is 7, which is normal, and does not suggest a external anion, and a predominantly elevated chloride is the cause, is contributing to a non-anion gap metabolic acidosis. All right, for the rest of the talk, we'll try and focus on the non-anion gap metabolic acidosis, and we'll try and discuss an approach to renal tubular acidosis, a very commonly discussed condition and often frequently tested on the boards as well. Non-anion gap metabolic acidosis should be considered as a phenotype where your bicarbonate level is low and your chloride is high on your chemistry. But you have to remember that a very important lookalike as a non-anion gap metabolic acidosis could be a respiratory alkalosis. A respiratory alkalosis where you have a chronic hypocapnia from any condition. Your body responds to that by lowering the bicarbonate concentration to get the hydrogen ion concentration back up, and when doing so will cause an increase in chloride as well. So your bicarbonate levels will be low, your chloride levels will be high, and it'll appear as if the patient has a metabolic acidosis, when in reality the patient has a respiratory alkalosis, and the only way of getting that diagnosis would be a ABG and looking at what the serum pH is. Now, once you rule that out, the most common cause of a non-anion gap metabolic acidosis is usually a iatrogenic chloride intoxication. A normal saline bag has a very high concentration of chloride of 154 milliequivalents, and when a patient is given a bolus of saline for a condition, let's say the most common condition that I would think of would be a diabetic ketoacidosis. The patient comes to you with volume depletion, the bicarbonate levels are depleted to some extent, and we replace that volume with predominant saline, depleting for the bicarbonate further, because the rise of chloride after a bolus of 3 liters would be to the tune of 6 to 9 milliequivalents, and there would be a drop of bicarbonate of net about 3 to 6 milliequivalents for that given thing. If you apply the Henderson-Hasselbalch equation here, I'm not going to go through the complicated equation, but remember that formula, that the rise in PCO2 will give you a high hydrogen, and a loss of bicarbonate concentration here is what is giving you a predominant acidosis in this condition of non-anion gap metabolic acidosis. The second most common cause of non-anion gap metabolic acidosis would be GI losses of bicarbonate. The GI fluid could be either lost with diarrhea, with certain surgical corrections or drains placed. It could be some urethral diversion or medications which are causing net bicarbonate loss. Diarrhea especially is very commonly associated with non-anion gap acidosis, and it's predominant because of a difference in the bicarbonate concentration between the diarrheal solution and the plasma. So plasma, the bicarbonate concentration is 24 milliequivalents per liter. When you look at bile solution, the bicarbonate concentration is 35 milliequivalents per liter. Pancreas, as high as 90 milliequivalents per liter. Small intestines, as high as 90 milliequivalents, and large intestines as high as 40 milliequivalents per liter. So imagine a patient who has an enterocutaneous fistula and that the ordinal contents are being lost into external ostomy bag. You may have a very high concentration of bicarbonate, and your kidneys may not be able to replenish all that lost base and keep that pH within the normal range. Urinary diversions are also very commonly associated with non-anion gap metabolic acidosis. The big problem here is that all the hydrogen ion that your kidney was working hard and getting rid of is going to get reabsorbed by the intestinal mucosa once the urine flows back from the ureter into that sigmoid pouch or the ileal pouch. The hydrogen ions will get taken back up again, and then your net loss of hydrogen ion will become really poor. So here there is no problem with the kidney acidifying the urine, but there is a net gain of hydrogen, and you are not able to get rid of the hydrogen as well as you should have. The third common cause of non-anion gap metabolic acidosis would be renal tubular acidosis. One of the key things to also remember when making or thinking of a diagnosis of RTA is that the renal function should be normal. When I say renal function, I'm alluding to the total GFR. The kidney is functioning normally, the GFR is normal, but there is some tubular dysfunction, perhaps in the proximal or the distal tubule, which is contributing to a loss of bicarbonate from the body and a retention of hydrogen ion, which is causing a persistent metabolic acidosis. And we'll go over as to how do we approach those patients. The renal causes of non-anion gap metabolic acidosis, or the RTA, can be because of three vital functions of the kidney in maintaining bicarbonate concentration. If the kidney fails to reabsorb all the bicarbonate, that could be a reason for a loss of bicarbonate from the body. It may fail to synthesize new bicarbonate and secrete a hydrogen ion, and that can lead to a net loss of bicarbonate. Or the kidney is able to do both of those two steps, but the hydrogen ion being produced don't have a vehicle to go out of the body that can cause RTA. And we'll discuss these three conditions in detail. The three steps of renal bicarbonate handling are critical in maintaining a normal bicarbonate concentration. Each step can fail and can cause RTA. When the proximal tubule fails to reabsorb all the bicarbonate, it'll cause proximal RTA. When the distal tubule fails to synthesize new bicarbonate and secrete a hydrogen ion, that'll lead to distal RTA. And when there is a problem where the hydrogen ion is being produced but is unable to move out of the body, that will lead to a type 4 or hyperkalemic RTA. And we'll discuss these in a little more detail. So here are your type 2, type 1, and type 4 RTA. So let's look at type 2 or proximal RTA in a little more detail. And I personally like to think of them as proximal distal rather than 1 and 2, where we get very confused. And physiologically, I think it's much easier to try and imagine and also think of it as to where the disorder is by thinking of them as a proximal, which is a problem with reabsorption of bicarbonate, and distal, which is a problem with secretion of the hydrogen. So proximal RTA is a condition where for some reason the Tmax of the proximal tubule to reabsorb the bicarbonate, which normally should be 24 millimoles per liter, has dropped down to say 15 millimoles per liter, right? So now when 24 millimoles of bicarbonate come down the proximal tubule, the kidney is only going to reabsorb 15 millimoles of that back. Okay, so there is some defect in the tubules there. And the rest of the bicarbonate is going to go down the loop into the distal. Some of that bicarbonate is going to be reclaimed back here, but then a lot of bicarbonate is going to go down into the drain, and the urine pH is going to be really high, right? Now, the process is going to continue until the bicarbonate level in the blood has dropped down to 15 millimoles per liter. At 15 millimoles, the 15 going into the proximal tubule is going to be all reclaimed, right? Because the proximal tubule can reclaim up to 15 now. The bicarbonate delivery to the distal tubule is going to go down. The distal tubule is functioning fine and is going to be able to synthesize any hydrogen that needs to go out and reclaim any bicarbonate, and the urine pH will be back down to 5. So in proximal RTA, the urine pH can be low, and the bicarbonate levels are probably only going to go down to a range of 15-18, the new set Tmax for bicarbonate reabsorption in the. So let's say this patient is given a bolus of hydrochloric acid. The hydrochloric acid is going to get buffered by the bicarbonate in the blood. The bicarbonate levels are going to fall in this patient down to say 12 millimoles now, right? All that 12 bicarbonate is going to be reabsorbed. Nothing is going to be lost, right? Because the proximal tubule is able to absorb up to 15 millimoles per liter, right? The distal tubule is working perfect. There is no problem here. The hydrogen ion is going to keep getting secreted in the distal tubule. The bicarbonate is going to get reabsorbed, and the patient's levels is going to go back up to 15. Now think of an alternate situation where when the interns see that this patient whose Tmax is 15, you see the bicarbonate level is 15, and you start aggressively giving bicarbonate IV or PO, and you say, okay, you know what, I've raised the bicarbonate level up to 20. So what's going to happen in the next 24 hours? The high bicarbonate concentration is going to cause 20 millimoles of bicarbonate to get filtered down into the proximal tubule. The kidney is only going to absorb 15 millimoles of that filtered load, right? Because that's the Tmax, a new threshold for bicarbonate absorption. The rest 5 is going to get filtered down into the tubule. The distal is going to keep doing its job like it does, but all the extra bicarbonate is going to get filtered out, and the bicarbonate levels are going to come back to 15 within a short period of time, right? So these guys are very difficult to get their bicarbonate levels up, and in effect, they really don't need to get the bicarbonate levels high up towards normal, because the daily load of hydrogen is excreted normally by the kidney, and the serum pH levels don't go down as low in the causes of proximal RTA are many. The most common cause seen are usually because of certain medications, either acetazolamide by itself or some medications, some anti-seizure medications that have the acetazolamide-like effect, certain chemotherapies. The thing that is frequently tested on the boards is a new proximal RTA in an elderly patient. And if associated with, say, high calcium or a low hemoglobin level, is almost always a multiple myeloma, right? Look for other signs of Fanconi syndrome, which is a combination of proximal RTA with glycosuria without hyperglycemia. Again, the Tmax of glucose is also reduced, similar to the reduction in the Tmax of bicarbonate in a patient with Fanconi syndrome. In those patients, think of myeloma as a cause of that proximal RTA. Lead toxicity can do that. Mercury poisoning, an old tetracycline capsule can also give you a proximal RTA. It can be because of certain genetic disorders, and it can be seen in chronic respiratory alkalosis. Right? In chronic respiratory alkalosis, so let's say you have a patient whose PCO2 was normal, and you suddenly lower their PCO2 levels because I'm having the patient to hyperventilate, right? As the PCO2 levels go down, remember the PCO2 divided by bicarbonate equals the hydrogen ion concentration. The hydrogen ion concentration is going to go down, right? And to get that equation back to normal, your body's going to start losing bicarbonate level, right? And this is going to be a persistent reduction of the bicarbonate level till a new steady state is reached. For every 10 that the CO2 went down, the bicarbonate will go down by 4. If the CO2 went down by 20, the bicarbonate should go down by, yes, 8. So that's the right answer, right? And the pH, which suddenly goes up when the CO2 levels go down, will slowly start coming back towards normal. It'll never go back to normal, but the ability of the kidney to reset the bicarbonate level is what is going to give you a normalish hydrogen ion concentration, right? So this is a key lookalike for a non-anion gap metabolic acidosis, right? So these patients will have a low bicarbonate, a high chloride, but the key here is that the serum pH is usually high and not low as it should be in a acidemia. The consequences of proximal RTA is predominantly a hypokalemia. Right? The high distal delivery of sodium to the collecting duct causes a net absorption of sodium by the principal cells, and for every sodium molecule that's taken in, a potassium molecule is lost to maintain electroneutrality. Right? In children with a chronic condition, there are some changes with the chronic acidemia. There are some bone buffering disorders, bone disease, there's decreased growth. Typically, these patients do not have stones because of a usually high serum pH, high urine pH that is maintained in these. Let's look at distal RTA and review what are the mechanisms for this condition. So the secretion of hydrogen ion in the distal RTA is primarily driven by a hydrogen ATPase pump, right? So this pump is tasked with shunting hydrogen out against the concentration gradient using active energy, right? And there is a set of enzymatic processes that are occurring in the kidney that use hydrogen and that is produced from water and CO2, right? The bicarbonic acid is broken down into the hydrogen and the bicarbonate. The bicarbonate is reabsorbed by the tubular bicarbonate chloride exchanger channels, and the hydrogen is shunted out. So the problem here is usually because the most common reason for this problem is when there is a lack of hydrogen ATPase pump, or there is some problem with the bicarbonate chloride exchanger in the distal tubule, and these patients are unable to reclaim the bicarbonate, which shuts down this process, or secrete the hydrogen ion, which shuts out the process. Right? The most common conditions associated with that are usually sickle cell anemia, Sjogren syndrome, probably the poster child test question for somebody with a distal RTA, but sometimes can be seen in other conditions. It can sometimes occur because of a gradient defect, right? So here in this particular problem, the kidney is able to secrete the hydrogen normally, right? The bicarbonate is working fine and is able to reclaim the bicarbonate normally, no problem there, right? But the problem here is the hydrogen that is secreted is unable to stay in the urine, and it diffuses back very easily into the tubular cell. Amphotericin B is probably the most common reason for this. So in these patients, the distal RTA occurs because the hydrogen that is secreted cannot stay within the tubulumen and goes back and is get reabsorbed, and your ability of the kidney to secrete hydrogen ion is taken away, right? The potassium losses keep occurring, and you have a hypokalemic distal RTA. The consequences of distal RTA are more severe compared to the proximal RTA. The bones, because of the chronic metabolic acidosis, which is severe or much more pronounced, the bicarbonate levels can go down as low as 5, 8 in some of the severe cases. It leads to a lot of buffering in the bone, phosphate and calcium reabsorption. This leads to a chronic hypercalciuria with a low urine citrate levels, and the persistently high calcium, low urine citrate, and an increased urine pH is the reason why you develop severe stone or nephrocalcinosis in patients with distal RTA. All right, let's review type 4 RTA or the hyperkalemic. Type 4 RTA, think of high potassium and chronic non-anion gap metabolic acidosis. That's the phenotype, right? So unlike proximal and distal, where the low bicarbonate is associated with a low potassium and a low serum pH, this condition has low serum pH, high potassium, and a low bicarbonate. And the problem here is the ammonia and how ammonia is critical in maintaining the hydrogen excretion from the kidney. So the hydrogen ATPase pump is working fine, there is no problem, and that's why it is not a distal RTA, it's a type 4 RTA. So why is that so? Intracellular acidosis stimulates an increase in ammonia generation by the kidney, and that's needed because whenever the cell is more acidemic or acidotic, it needs to reverse that process by losing hydrogen from the body, and it increases ammonia generation, which will result in doing so. But intracellular alkalosis suppresses ammonia generation, right? So when you have an increase in serum potassium from any reason, potassium moves into the cell and hydrogen ion moves out to maintain the electroneutrality of the cell. So hyperkalemia from any cause leads to a state of intracellular alkalosis, which is the main reason why ammonia generation goes down in somebody who has a type 4 RTA. So that's an important thing to remember. As the ammonia generation goes down, right, the process leads to a persistent high hydrogen in the body and a lack of secretion from the kidney. Look at it in another way. So you have a patient who is normally secreting hydrogen ions from the distal tubules, right? The hydrogen ion comes out, ammonia is needed to take that hydrogen ion and shunt it down into the urine, right? Now you have another condition where the hydrogen is being secreted, but the level of ammonia in that patient is really low, so they're only about half or a quarter of the normal amount of ammonia generation in this patient. Now the hydrogen ion in the tubular side is going to keep getting to a concentration which is going to reach a point where instead of all of it going out, it's just going to stay there. The pH is going to go really low, and it cannot go any lower than 5, and hydrogen is going to start diffusing back into the cell, and the secretion of hydrogen ion will cease. So there is nothing wrong with the kidney's ability to push hydrogen out from the hydrogen ATPase, and hence it's not distal RTA, but the problem lies in an ability of the kidney to lose hydrogen out of the body, and maintain hydrogen excretion at a regular rate. So in these patients, the urine pH may be low, but the net acid excretion is really low. So how do you approach diagnosis of a patient with RTA? I think the key part is you need to be able to assess whether the kidney is able to push hydrogen out, how much hydrogen is being complexed with ammonium, and how much of it is coming out as a titratable acid, right? So to do that, we really have to look at the ammonium concentration in the and calculate the ammonium concentration using what we call the urine anion gap, right? So in the presence of ammonium, right, ammonium is going to link up with the chloride, and if there is a lot of ammonium in the urine, the sum of sodium and potassium minus the chloride is going to be negative. Okay, so ammonium in the urine usually will rule out a renal tubular acidosis type 1, right? So ammonium in the urine should rule out a type 1 RTA or a type 4 RTA. In the absence of ammonium in the urine, right, the sodium and the potassium usually would be equal to or more than the chloride, right? And a positive urine anion gap is telling you that the metabolic acidosis could be because of a inability of the kidney to make ammonium. This could be a distal RTA 1 or 2 in this condition. So in a person with non-anion gap and metabolic acidosis, let's see what the urine anion gap should look like. So when you have severe diarrhea, the kidney is working very well in pushing all the hydrogen out. The ammonium is working fine, and your urine anion gap would be really negative, right? Whereas in a proximal RTA, it kind of depends on what is happening at baseline. So at baseline, when the amount of filtered bicarbonate is at Tmax, there is nothing wrong with the distal tubule, and the urine anion gap may be negative, or it may depend on how much hydrogen ion the patient is consuming every day. Whereas when the patient is getting a lot of bicarbonate supplementation, there will be a loss of bicarbonate from the body, and the urine anion gap would be positive because of a very high amount of sodium that's going to be shunted down into the tubule along with the bicarbonate. When you give the patient a acid load, right, and you're testing the patient's ability to secrete that acid, the bicarbonate in the proximal tubule is going to get reabsorbed without any problem up to the Tmax of 12. The distal tubule is working fine and is going to push the hydrogen out. The ammonia generation is fine, and the urine anion gap would be negative in that particular state in a proximal RTA. In a distal RTA, there is problem at the level of the hydrogen ATPase or generation of ammonia, and the urine anion gap would be positive. But in a patient with type 4 RTAs, when the amount of hydrogen ion concentration is really high, the urine pH would be low, and the urine anion gap would stay positive because the ammonium generation, though, is really low, even though the urine pH is low. So the table here summarizes the response of urine anion gap in different conditions of proximal RTA or non-anion gap metabolic acidosis and what the response of the urine anion gap would be. There are a few limitations of using urine anion gap in some conditions. The most common ones being when there are excess anions. So think of it, a patient who has sodium, uh, say phosphate or sodium lactate or sodium linked with a X anion, right? So the high amount of sodium X anion, when it goes down the kidney, the sodium level is going to be in the urine in a very high concentration, but it's not going to come with chloride, right? And that will lead to a falsely elevated urine anion gap, even though the ammonium is high. So in those conditions, you should use or if you suspect such a condition, think of getting a urine osmolar gap. I'm not going to go into that detail, but it is better because it will look for ammonium concentration, but not be affected by the anions present in the urine. Another condition is very important clinically is the urine sodium should be more than 25. Right? Why is that so? A low urine sodium depletes the kidney's ability to excrete acid. There are sodium hydrogen exchangers in the proximal tubule and in the distal tubule, and those are critical in secretion of hydrogen ion, and a low urine sodium depletes the kidney's ability to excrete hydrogen ion, and the GFR is going to be really low in those patients as well. So you have to make sure that you check a urine sodium. The urine sodium should be at least 25 and above to be able to check for a urine anion gap and its contribution to a patient in a non-anion. The urine anion gap is in this patient. So in this particular patient, you have the urine sodium 80, potassium 45, and chloride of 115. So your urine anion gap would be, there's a typo here, 125 minus 115, so would be plus 10, or a positive anion gap. Even if it is zero, it'll tell you that the patient has a very poor ammonia generation and should suggest that this may be a RTA and likely a distal RTA because your potassium levels are low in this patient, right? So let's go back to the steps one more time. The after you've done those 3 steps and you've made sure that the patient is compensating well, and you applied your compensation to this patient, the next step is to also check for the the serum anion gap and make sure that the anion gap is normal, right? So in this particular patient, we calculated the compensation, that's normal. The anion gap in the patient was 7, so the final diagnosis for this patient would be non-anion gap metabolic acidosis because of this RTA. Take another patient, a 34-year-old, history of diabetes in a 74-year-old patient. Now in this patient, you have a high potassium along with a low serum pH. Right? So let's plug in these numbers. What is the primary disorder in this patient? So the serum pH is low, right? So this would suggest acidemia, right? And the primary process here should be PCO2 is low, so it cannot be a respiratory disorder. The bicarbonate is low, so it should be a acidemia, right? And low serum pH with the low bicarbonate suggests that this is a metabolic disorder. So metabolic acidosis, if you look at the the PCO2 using the Winter's formula. The expected PCO2 is anywhere between 31 to 35, but the patient's PCO2 is 38, right? So 1.5 times the bicarbonate plus 8 gives you a 31 plus 35 number, but the patient's PCO2 is higher. So this would suggest that there is a combined metabolic acidosis with a respiratory acidosis in this patient. You need to calculate the anion gap. The anion gap is a little negative in this patient, and sometimes that could be a pretty surprise in some of your patients. The low anion gap can be sometimes seen in certain conditions. It's usually most commonly seen when the chloride levels are very high, right? And this could be because of some patients with very high triglycerides. If a patient has an iodine or a bromide poisoning, or levels that are elevated, the chloride levels are spuriously elevated because the lab reports the chloride as an error, and it counts bromide as 2 or 3 chloride molecules. It could be because of decreased levels of unmeasured anions, right? The most common cause of a low anion gap is low albumin, or where the phosphorus or the IgA levels are really low in some of these patients. And in some patients where there are unmeasured cations that are really high in some patients. Hyperkalemia, hypercalcemia, high magnesium, very high lithium levels can give you a very low anion gap. So again, clinical pulse to try and apply those in patients who have a problem. So in this particular patient, we look at the urine anion gap now. The urine anion gap is negative. So it is suggestive of some ammonia, but despite that, there is a very high acid level, and the bicarbonate level is only 17. The urine pH is 6. So it does say that there is low amount of ammonia in the urine. So this would be a non-anion gap metabolic acidosis with hyperkalemia. And it could be because of two potential mechanisms by which you can get that hyperkalemic RTA. It could be very rarely because of a condition where there is a voltage dependent distal RTA. But the most common one is when you have a hyporenin, hypoaldo state and a persistently hyperkalemic RTA in these patients. So what is this voltage related distal RTA? The voltage distal RTA is sometimes seen in patients where the mechanism for acidification of the urine is broken because of a inability to absorb sodium in the distal RTA, in the distal tubule. The sodium levels are normal, but let's say if you have the patient on, say, trimethoprim or amiloride, and you block that ENaC channel, the sodium levels do not get reabsorbed, right? And if the sodium absorption is impeded, that leads to a reduction in the hydrogen secretion and an inability to maintain a net positive gradient inside the cell. And without that, the hydrogen secretion goes down. In these patients, the level of aldosterone will normally be high, and they will not respond to use of fludrocortisone, which should reverse a type 4 typical RTA because of hyporenin, hypoaldo state in a typical type 4 RTA. So that's usually very rare to have that, and it's usually associated with some predisposing condition which leads to a voltage-dependent distal RTA. A couple of cases and see if you can practice what we have reviewed so far. So you have a 25-year-old man, and chief complaint is recurrent kidney stones, right? So when you look at the labs, you see that the bicarbonate is low, right? The potassium is low, so a hypokalemia with low bicarbonate levels. And you've got some urine labs here with a urine pH, right? Now this, if you have a serum pH which confirms that you have a low serum pH or a patient with persistent acidemia, then this would be a type 1 classic distal RTA, because your sum of sodium plus potassium would be 55 plus 23, that's 83. 83 minus 73 would be a plus 10 urine anion gap. So urine anion gap is positive in the face of a persistent non-anion gap hyperchloremic metabolic acidosis. Urine pH is high, and I would suggest that this would be a class type 1 distal RTA. Let's take another case, a 36-year-old diabetic since the age of 12, retinopathy, neuropathy on insulin and ACE. So your potassium level is high, urine pH is low, bicarbonate is low, right? So it's a sign that there is hyperkalemia with a non-anion gap metabolic acidosis. The anion gap is 142 minus 132, which would be 10. So your anion gap is normal, right? So this would be a type 4 RTA, right? Especially, I'm giving that the serum pH is low in all of these patients. So it'll be a type 4 RTA. And the management of this patient is dependent on whether this patient has signs of volume overload or hypertension or not. If the patient is volume overloaded and has hypertension, the key thing is to get this potassium low. As the potassium level goes down, the urine ammoniogenesis will increase, and the kidney should be able to get rid of that extra hydrogen now. But if the potassium stays high, that would be a problem. If the patient is hypotensive, the volume is low, you can put the patient on fludrocortisone, and that will lower the potassium levels, and the acidemia would. All right, let's look at this patient, 45-year-old with alcohol abuse, complains of occasional diarrhea. The anion gap, so let's look at the bicarbonate is 17. Your anion gap is 17 plus 7, 24. 132 minus 124 is 8. So anion gap is normal, right? So this appears to be a non-anion gap metabolic acidosis, right? But if you get a serum pH, you get a high serum pH and a low CO2. So this is suggestive of a respiratory alkalosis with a hyperchloremic hypocapnic response and a adequately suppressed bicarbonate level to compensate for chronic respiratory alkalosis. So that's the point I was trying to make earlier, that you have to be careful in making sure that you do get a good assessment of your serum pH before you come to a final diagnosis. And just because the patient has diarrhea does not mean that the patient has a non-anion gap metabolic acidosis. Okay, let's look at this patient, a 36-year-old diabetic who's been seen in your clinic a few weeks ago. His labs kind of look normal. He gets admitted because of, say, abdominal pain and has not been taking his insulin regularly. His anion gap, which used to be 142 minus 135. 7 is now elevated to 132 minus 108. So it's significantly elevated now, right? The potassium is elevated. So this patient here has a diabetic, likely diabetic ketoacidosis. And the patient is riddled with nausea, vomiting. So you put the patient on IV fluids and start the patient on insulin, right? The glucose is elevated at 600. So after 6 hours, you repeat the labs and you get this. The anion gap now is 135 minus 129, which is normal. 6, the anion gap is closed, so it looks like the DKA is resolved. But what we talked about earlier, the high chloride solution and the replacement of the lost bicarbonate with chloride-rich solution leads to a iatrogenic non-anion gap metabolic acidosis because of hyperchloremic solutions. If you look at the serum pH is low, the CO2 is 30. So let's calculate the compensation here. The bicarbonate is 14, so the predicted CO2 should be 1.5 times 14, so that's 7. 1.5 times the bicarbonate plus 8, right? So 1.5 times 14 is 14 plus 7, 21. 21 plus 8, 29. And the patient's CO2 is 30, so that's within plus minus 2, so that's normal. So here your final diagnosis would be a non-anion gap metabolic acidosis from hyperchloremic fluid resuscitation. So I know there's a lot of information here, and what I would recommend you to do is to really go over the concepts at least 1 or 2 times. It's going to help you kind of catch on to where and how do you apply the principles of differentiating first a phenotype of and identifying a phenotype of non-anion gap metabolic acidosis. The phenotype is low serum bicarbonate with a high chloride solution. Once you see that, the next step should be to try and get a serum pH and confirm that you have an acidemia. Right? If you have an acidemia along with a NAGMA phenotype and you are worried about RTA, the first thing you need to rule out is those 2 big categories of non-anion gap metabolic acidosis. The iatrogenic high chloride fluid resuscitation, and that's very commonly seen in patients who are admitted to the hospital. The other talk on AKI, I had a slide on the use of balanced solutions versus hyperchloremic solutions. And there is an increased evidence and concern being raised that high chloride solution can increase the risk of stress and oxidative stress within the cells and may increase the risk of acute kidney injury and possibly may be associated with morbidity within ICU patients and even in some floor patients. So there is a renewed interest in looking at the role of balanced solutions. So iatrogenic chloride excess in the hospital is probably the reason that I try and make sure that when I'm working up these patients, I'm looking at them as an outpatient in a steady state versus trying to make a diagnosis of RTA in the hospital. So that's one. The second big category is the GI losses of bicarbonate. And here you have to again remember the very high concentrations of bicarbonate in the pancreatic and the small intestine fluid, and if there is a persistent and a consistent loss of those fluids, the patients can lose a significant amount of bicarbonate. It could be a patient who has a urethral diversion, and in those patients, the hydrogen ion being secreted as ammonium get reabsorbed, and the lack of secretion of that ammonium chloride from the body leads to a high chloride concentration. The chloride is exchanged for bicarbonate, and you lose more bicarbonate in that enteric pouch or the ileal pouch. So you have to be astute enough to recognize that. And the key test is a urine anion gap, and I went over how to apply it and what are some of the shortcomings of it. As always, if you have questions or cases that you want to discuss, feel free to get in touch with me in my office or on Twitter at KidneyLSU. Thank you so much, and have a good day.